you so much. Go ahead.
All right, so yeah, I'll kick it off. Representative Matt Byrong. I represent Northeast Addison County, Virgins, Panton, Waltham, Ferrisburg, and Virgins. So I also own Three Squares Cafe in Virgins, and as Rachel stated, I sit on the CSAC board. And who shall we go to next? Senator Hardy, there you are. I haven't seen you in a while. Throw it to you.
Hi, Matt. It's nice to see you. It's nice to see everyone. Hi, my name's Ruth Hardy. I'm one of the 2 state senators representing the Addison district, which is all of Addison County, plus Huntington and Buell's Gore. I live in East Middlebury, and I serve on both the Finance Committee and also am Vice Chair of the Health and Welfare Committee in the Senate. Thanks. I will go with Amy Sheldon.
Thanks, Ruth. Hi, everyone. I'm Amy Sheldon. I represent Middlebury in the legislature in the House, and I serve as the chair of the House Natural Resources, Fish and Wildlife Committee. And I also live in East Middlebury. And I am seatmates with Representative Robin Scheid, who I see, and I'll tag off to her.
Amy, and thanks to all of you at CSAC for organizing this meeting today and inviting us. So I'm Robin Scheid, and along with Amy, represent Middlebury, and I sit on House Appropriations. And I can't tell who else is here from my particular screen. Oh, I see Harvey. I see Representative Harvey Smith. So I'm going to pass it to Harvey.
Hello, I'm Harvey Smith, and I represent the towns of New Haven, Weybridge, and Bridport. And I also serve with Amy Sheldon on her Natural Resources Committee. So I have no idea who else is here. So
Diane, do you want to go?
Sure, thank you. Diane Lanfer, Representative Lanfer. I serve on House Transportation Committee that I chair. I am district mates with Representative Brong on Addison 3, which is, as he stated, Ferrisburg, Virgins, Panton, Waltham, and Addison.
Great.
Thanks.
So I'm going to share my screen because we have a little bit of a presentation. So bear with me. And well, again, thank you so much. We have it's a packed meeting, and we have a lot of information to share. But essentially, we're going to really, yeah.
The screen share is weird. It's only half.
Oh, okay. Hold on. It's because. Hold on. All right. The wonderfulness and the awfulness of Zoom. So, hold on. All right, let's try it again. Can you all see that? Is that better?
yeah.
Okay, great. So I thought we've gone through introductions. Thank you so much. And we really wanted to talk about the state of CSAC and the overall system of care, the community-based mental health and developmental system of care. I wanted you to hear about our program updates. Despite the enormous amount of stress and pressure that we are all experiencing, CSAC has been working diligently to meet the community's need. But most importantly, I wanted for all of you to hear from staff, from our frontline staff. So we've reserved some time so that you can hear directly from them. And then I'm stealing this tagline from our colleagues in Washington County, which is essentially ask us anything. What's on your mind? What has this prompted? Please ask us. Where can we provide insight and clarity? What else would you like to dive into? And I hope that for all of you that this is just the start of a conversation. It's a pretty critical time for social services, community-based social services, especially for mental health and developmental services. And I encourage you to, reach out and have follow-up conversations with us. And, there's a couple of things brewing that you're probably, some of you are looped into in terms of broader community conversations. So I consider this a start. So go ahead, Alexa, I'm going to turn it over to you.
Thanks. My name is Alexa Eiler. I'm the HR director here at CSAC. Thanks to everyone who's making time to be here for this important conversation today, and especially to the legislators. I'm so impressed by the relationship that we have with our Addison County legislators and how generous you are with your time. You're here more than today, and we've got a long history of working together, so thank you. It is no surprise, I'm sure, that CSAC is struggling with our workforce. There's some data on the screen about where we are currently. The bottom line is that our turnover in terms of people leaving us has been about what we expect, but we've been unable to hire to the same degree as in previous years. So we have situations where consumers and clients are going without care because we can't staff their services. We have situations where staff teams are doing emergency reassignments in order to cover some essential services. And we've had some very heavyweight retirements, not more numbers of people leaving us than normal, but some of our very, very experienced people with large capacities have left us, which I think is a dynamic that's familiar to other organizations as well. But one of the biggest barriers to hiring, I mean, we all know that there's a shortage of folks, that it's a job searchers market. And for our positions that do direct service, our starting wage is $15.20 an hour. And that is just increasingly difficult to compete with when there are so many other kinds of meaningful work that start much higher than that. CSAC has always been on the lower side of the market, but the gap between what we can offer right now and what the market bears is higher than it's ever been. On the other hand, our staff are amazing. There's 91% of the staff who answered the staff engagement survey said that what they do, they see that it is directly connected to our mission. And 90% of our staff said they're highly motivated to help the organization succeed. So what we do have going for us is our culture, the meaningfulness of the work, and what's just really, really difficult is the pay. Only 22% of our staff said that they felt their pay was competitive in the nonprofit market, never mind the sort of full market. CSAC has always had a lower turnover rate historically than some other DAs, and which is great. So the struggles that we have right now are certainly struggles that are shared in the rest of the system. And there's some statistics there about how the labor shortage is affecting across the state mental health services. Rachel, is there anything else you'd like to add to that?
I wanted to just highlight quickly that, as Alexa pointed out, we've got about 900 openings across the entire DA system. So while CSAC is probably, we're struggling, we're not struggling as much as some of our partners, but across the entire system of care, it's hurting. The 900 plus vacancies are having a material impact on access and capacity, our ability to serve people in the community setting.
Oh, I hadn't seen those pictures before. That's my department in the PJs. That was our Halloween picture last year. And that looks like one of the residential programs. So COVID, it's hard to, I don't even know how to start describing the effect of COVID on us. The most immediate thing that's right in front of us is the CMS vaccine mandate. CMS is the Centers for Medicaid and Medicare. And they have, on November 5th, put out some rules. This is different than the OSHA rules, that anyone working in healthcare needs to be vaccinated or have an accommodation. And like everything related to COVID and government mandates, has been written in haste, for good reasons, to deal with urgent situations, but then figuring out how to apply it to our work is hard with the CMS mandate, and it's been hard with other mandates as well. It's certainly clear how it applies to hospitals, but not necessarily to kind of mixed use organizations like CSAC. If it does apply, we are looking at a staffing collapse in a couple areas where we would have to, we've identified one program that we would likely close and identified impacts to clients in other areas. So it's not clear to us. We're getting conflicting legal opinions. All the DAs are trying to figure this out. It takes an enormous amount of time administratively, and it causes staff, we have staff who are thinking they might not have jobs. And we certainly are worried about being able to continue to provide the services that are critical to consumers. So we're struggling to figure that out. In terms of other effects, we have been really lucky here. The early part of the epidemic, we were really worried about some of our clients, especially in residential settings, especially who had other risk factors. And our outbreaks in the residential programs, we've had them, but they were more recent and after people were immunized. So we have had to put people in quarantine, which in the rooms, which has not been fun. And we've had to have staff, do the whole PPE thing. But overall, I would say we've still been really lucky. And I want to draw the attention of the group to the partners that we've worked with at the Department of Health. The epidemiologists, and especially our local Department of Health folks, have been incredibly responsive. And we know that they are also working under intense pressure as well. So they have helped us manage the outbreaks at facilities, and our local Department of Health folks have been just responsive to every kind of question we might ask. We've had staff, non-residential staff who have been, and non-residential clients who've been affected by COVID and have had to quarantine, which was, one thing when there were some programs that existed to help replace income for those folks, but is a real hardship now when folks have to quarantine and they have to use their paid time off. Most of our workforce is at this point vaccinated. We had early access to the vaccine and a very good uptick rate. We have about 300 staff overall, and 20 to 25, depending on how you count it, are unvaccinated, but we just can't afford to lose even one of them. We're in a situation where if, somebody leaves a program, the program may not be able to serve folks because they're already so short-staffed. So COVID is, an enormous part of our daily work in a way that it wasn't before, and a threat to health and safety, life and safety, which just is an entirely new dimension. We've always dealt with very serious things, some of which were life-threatening, but this is another dimension of decision-making that has huge impacts on clients and staff. Rachel, would you like to add anything to that?
No, thank you. So, most of all of our effort we try to put towards serving people, both on our DS side and our mental health side. But as Alexa has spoken to, the impact of staffing, COVID, have really sort of whittled away at our ability to be in front of staff more. And another big issue is around system and payment reform. As some of you are aware, both sides of our house, DS and mental health, are going through both systems and payment reform. And it's happening, it's there. And I bring it to your attention just because it's another stressor on CSAC, on a community mental health and DS agency. And it impacts staff's ability and work satisfaction. And so just want to point that out, that's another area where we're spending an enormous amount of time working collaboratively with the state. We're always in step and working with the state to figure the right path forward so that it's the outcome of our reform efforts are good for the community and are good for people. But it does take up a lot of time and energy, which is not put into client services. So the impact on all this is, what I'll say is, I'm just so incredibly grateful and impressed by how hard working our staff are, how creative and nimble this agency has been. I mean, we've reorganized several areas across the agency to not only protect access, but to speed up access to services, knowing that we're seeing increasingly higher numbers of people who need care. We're seeing a greater level of acuity. So we've been really transforming certain parts of the agency to step up and meet the need. But I will say it's starting to feel like we're scraping the bottom of the barrel a bit of our ability to be creative, to be nimble. And we're definitely, at CSAC and across the system in a bit of a crisis because of staffing and our ability to just not be able to recruit very effectively. And what that means for staff, when we survey staff, and whether it's our annual staff survey or, as people are leaving an exit interview, is the high administrative burden, which is I think unique to the DA system, is having an impact on job satisfaction. The increasing acuity of clients and consumers is having an impact on job satisfaction. And the ability to earn more with less administrative duties in other settings is having an impact on our ability to recruit, because there's other jobs out there that pay more and you don't have to go through the same sort of administrative burden that exists when you work at a DA system. Now, I'll give you an example. In our youth services, through our assessment process, a youth has to answer, through the assessment process, anywhere from 170 to 300 plus questions before we're able to really enroll them in appropriate services. So that just takes up an enormous amount of time before we can actually get somebody, get to the heart of the relationship, the heart of working on issues that matter. And that, I think, contributes to burnout and job dissatisfaction. So, we've been thinking about, what is our ask of you? And again, as Alexa said, we've always had such a wonderful collaborative relationship with all of you, and we're so grateful for that. But this feels like a pivotal year. It feels like a really critical year. And our ask is to, as you're going through the legislative process, the DA system needs a really significant Medicaid rate increase to bring salaries for both our staff and our contracted workers, so that we can achieve, so we can successfully recruit and keep people. We're increasingly eroding in that area and really, really struggling. We need to be able to give our staff annual increases in line with the state workforce, again, and also to keep up with inflation and to be able to reward length of service. We need to be able to, we love an increase to our bundle for specific positions or to advance effective models. Later on in this presentation, you'll hear about the living room model. But again, we struggle to really figure out how to make things, new innovative programs sustainable. And we need your help. We want one-time, there's a lot of FMAP dollars coming in, and we'd love to see some investment in one-time, investment in recruitment and retention to really stabilize our workforce. We'd love to see the increased dollars for tuition reimbursement and student loan forgiveness. There are dollars coming in for the mental health side, but DS, developmental services, was left out. So not only do those dollars need to increase to really have a meaningful impact, but we need to include all of our services, not just mental health. And I also ask that folks both at the administration level and in the legislature understand that the DA system, we're doing incredible work. We're moving forward. People are getting served. I mean, so much of what we do is silent, but effective. But we're operating and should be considered that we're operating under crisis standards of care. And we ask that our targets are relaxed, and if we can't meet the numbers around our payment reform efforts, that because we're in a global pandemic still, that we're not penalized for that. That when we emerge from this pandemic, you want a system of, a strong system of community mental health and DS agencies, a strong DA system that's there to meet the community need. I'm going to turn it over to our program directors to give a brief update on their various programs. So Greg, you want to kick it off?
Sure. Hi, everyone. My name is Greg Mears. I'm currently acting director of developmental services. In the past, I've done a lot with adult mental health, but I'm more focused on the DS community at this stage of the game. So I want to start by saying how much I hate COVID. Everything about COVID, I hate. But there have been a few things around the workplace that have caused us to change in directions that we've wanted to or had thoughts about for a long time. Certainly address things that families had wanted, and COVID made those come to the forefront. The biggest one was how to stay connected and social interaction. So COVID hit and the world shut down and most people stayed at home. Clinicians did 100% on computer. That's not the case in the DS world. I mean, our folks need 24-hour supports around safety and supervision, and that did not change during COVID. So my staff were on the ground floors with people from day one. Granted, we had many people with personal situations that needed to sort of not work as diligent, but that only meant that others stepped up. So as most other services in the world sort of did a new way of functioning, ours sort of did a new way, but still functioned, and have done direct services from day one. What that meant was we really needed to do plans of care on a regular basis, sometimes every month for people around their COVID needs, and prioritize because we only had so many staff. And even today, we're still prioritizing. So the DS program here, CSAC, is not functioning much different now than it was at the beginning of COVID. Staff are really exhausted. But some things that have come out of that are positive is, one, our direct care force used to be separated between employment and community staff. COVID made them do whatever was needed on the fly. And so we sort of reaped the benefits of that and changed their job titles to direct service professionals, which means there's no longer isolated program staff for employment and community. They all do a combined service, and that's really good. It provides us access to national supports and training opportunities, and there's an initiative nationwide around that workforce and building that community as a professional community. So that was exciting. The other big thing was really addressing the social aspect. So we moved a lot of our services to Zoom. So we have classes and, reading books and movies, and I mean, every social thing you can do. We do about 2 or 3 or 4 a week now. During COVID, we were doing 2 a day. But families have really found that that's helpful. For those people who don't have services at home, it's a way to stay connected with their peers and with staff. And so that's really addressed isolation. And so that's been outstanding. And families have been asking for that for, I would say, the last 10 years, and we haven't been able to pull it together. And I think that's something that will stay going forward. But I just really want to highlight how tired people are and how amazing. I couldn't have done it without the direct service people. They've done all the work. Managing it has been really hard, and it goes minute to minute, but they're the ones that are on the lines and bringing it home to their families, and they keep coming back. And so it's to them that I owe all the gratitude in the world. So that's what I have, Rachel.
Thank you, Greg.
Yeah.
Sandy?
Sure. Hi, everyone. I'm Sandy Smith. I'm the Director of Adult Mental Health Services. I oversee community rehabilitation and treatment services, adult outpatient and SUD, psychotherapy services, and the emergency service system for adults. It's been a really difficult stretch in adult mental health. As has been described, the staffing shortages have impacted our capacities to respond at a time when there's increased need and acuity in our communities. And it's been a kind of rolling blackout dynamic of staffing shortages in different areas of our service system. particularly with our emergency services. For example, we have some of our clinicians from CRT and from other programs that allow patient helping out with the emergency services. Also some case managers helping out, but then at the same time, we're experiencing some shortages in our case management capacity that at one point I counted that about over a third of the CRT population is undergoing some transition of who their primary assigned case manager is. You know, and we're also hearing from community partners that they're dealing with more acuity. They're wishing we could help and respond. And with some of these staffing challenges, it's been hard to have the bench depths to, you know, mobilize supports into as well. You know, as was described earlier, the impact of COVID and potentially with the vaccine mandates, it's, you know, our residential staffing has already been thin and stressed, and certainly when we have, you know, positive people testing positive, or with the vaccine mandates, potentially we're in a really serious situation in terms of the core staffing, necessary staffing of our residential programs. Through all of this, though, we've been trying to keep our eyes on possibilities to really realign our adult mental health service system in ways that we think can best respond to our community needs with the resources that we have. And we have listed here a few of the things that that we've been working on. The Citizenship Project is a grant funded, it's one of the COVID grants that we're using to offer a course and group support for people using the 5 R's of rights, responsibilities, resources, relationships, and meaningful community roles. And we're hopeful that this is a course that people who are, say, coping with homelessness could you know, benefit from participating in, and there's some incentivization for people to be taking part in this. So that'll be starting in January. With our Open Dialogue project, we're trying to involve personal networks in times of crisis, and we believe this can help avert some of the longer term involvement in services that might otherwise occur. And we have repeatedly seen it help to avert hospitalizations and pressure in that part of our system of care. Over the last year and a third, we've been running a project called MyPad, which is a staff-supported apartment program for people who have been otherwise in really extended stretches of psychiatric hospitalization. And it's been a really challenging year, high levels of acuity, with staff who are working long hours to cover the gaps and with some of the staffing shortages. But at the same time, we're really seeing some you know, significant success in terms of helping people stay out of the hospitals who otherwise would be in them for very extended periods of time. We think this is a really valuable model that we'd love to make more broadly available to other people we work with in the county. If we could figure out you know, some kind of funding source to support some expansion of this approach. We're reorganizing our case management services with the combining of CRT case management and the other non-categorical case managers in adult mental health, in hopes of having more capacity to respond to crisis needs, consultation with our community partners. And, you know, I think one of the challenges we're hearing from our community partners is with people who are showing indications of major mental health conditions, but aren't themselves seeking out the kinds of supports we would be offering, which, you know, I think makes sense if you think about someone who's dealing with, you know, just life-threatening uncertainties about where they can live safely and be sheltered and, you know, meet basic needs. You know, kinds of tools we have in regular mental health services aren't exactly where they're at, but at the same time, we want to be available to our community partners and, you know, offer what support and consultation we can, and try to offer opportunities for engagement and support for the people they're working with. And then recently, we're just starting a new embedded position with the state police. And so this person will be available both for situations that the state police are responding to, but also for our different town police programs, police teams to call them in as well. It's been really tricky to try to make these shifts in a time of crisis and with staffing shortages. These all feel like directions that are really important for us to keep working on as best we can. So thanks for coming and thanks for listening.
Thanks, Andy. Cheryl, you out there?
I am. Hi, everybody. I'm Cheryl Huntley. I'm the director of the Youth and Family Programs. You know, the news from Youth and Family, I think, is just how incredibly appreciative I am of our staff and of their resiliency. They have worked so hard to get kids and families to be seen. You've seen the news from the schools, and it's true that kids of all ages are really struggling right now. You know, in mental health, our business is stress, and we end up dealing with it all the time. We're pretty good at both acute and chronic stress. But I think for all of us, this pandemic has really taught us more about what the persistence of stress really means. And, you know, none of us do very well when we're in chronic stress. We're all cranky and irritable, and we don't think very clearly, and we get tired. We don't pay attention as well. We don't do our work as well. And kids are just as susceptible to those kinds of stresses. And in fact, they often tend to sort of soak up the stress of the adults that are around them. And we've seen that in kids. We've seen increasing kind of behavioral reactivity in kids, and our older kids are really struggling with a lot of depression and anxiety. We've got our school team leaders here today, and they're available, I think, later if we have further questions about sort of what that looks like. What we've been working to do is, in trying as hard as we can, is to be creative so that we can see as many kids as possible and create access to care as quickly as possible. We have been trying to expand our intake capacity to so that we're assessing kids' needs as immediately as possible. We've expanded our approach to family therapy and have been using mobile family work as part of our crisis response. We've been expanding group options. We've been really trying to support teachers as well as students in our school-based clinician positions. And we've been doing lots of teaming with schools and DCF so that we're working hard to, together to come up with responses. And, all of that's helping. The need remains really high. We've been excited to be moving forward on trauma-informed approaches to supervision in youth and family. And we have restructured our program with a focus on really supporting staff, both individually and in a peer group model. I just think for all of us in times of high stress, it's important to build resiliency through strengthening our connections with each other. And I think that's a piece of what we've been trying to do in our supervision model and in our school and community work. Our staff, families, kids, community, we all need to be together right now as much as possible. And, connections build hope. And that's what I think we're all kind of needing a dose of right now. So thank you.
Thank you, Cheryl. Joe and Genevieve.
Hi, everyone. I'm Joe Lassick. I'm a psychiatrist and medical director here at CSAC. And I was hoping to talk today about psychiatry here at CSAC and in Addison County. What I think we're seeing here in Addison County is similar to what we're seeing throughout Vermont and nationally. And that's a 2-decade long trend in reduction in availability of psychiatry. And over the last 2 years, I think we could consider this a crisis level of availability of psychiatry. Here at CSAC in the last year, we have seen really significant changes and significant loss. We had the retirement of Dr. Jimerson, who was here for 33 years as medical director. We also had our child psychiatrist, Dr. Bashul, leave after 7 years. Both were much beloved and did a lot for the folks of our county. And then only a couple weeks ago now, we had the tragic death of Barbara Hammerland, who was a nurse practitioner that served Addison County for the last 40 years. So we're really reeling from a lot of change here. And one thing I want to also say, you know, at the same time we had those losses, as we also had the great fortune of having Dr. Genevieve Williamson join us this past summer. And already I would say she's made a huge impact on the work that we do, serving children, adolescents, families, and also all the adults in our CSAC programs. Since I've come to CSAC a little bit more than a year ago, I've heard from community partners throughout the county, including Porter Medical Center, the primary care practices, including Mountain Health, our FQHC, that lack of access to psychiatric care is one of their largest concerns. Of everything that's happening at a time like we've gone through in the last 2 years, this is something that we're hearing over and over is one of the biggest concerns that our partners have. Unfortunately, as this need seems to be growing, our ability to provide psychiatric care and access to the community has been reduced through these staffing changes that I've talked about. So what we've really had to do is focus in on our core programs, our youth and family, CRT, developmental services, and emergency services programs, and our availability to be there for our community partners has been reduced. Though we have been working on certain programs and options that might improve access. One of the things we have done is try to improve referrals, streamlining referrals into psychiatry, and also looking to transition stable patients back to their primary care homes. We've also established contracts, including a contract with Porter Nursing Home to give them more support, which I think has generally worked very well. We've been talking with Porter Medical Center about possibly providing contracted services there in the emergency department and on their inpatient units. And also looking to the future, looking at innovative ways to support primary care in having patients stay in their primary care home, but having psychiatric support provided. And that can be done in different ways, including through consultations to primary care doctors from psychiatry, and a newer model called collaborative care, which I'm particularly excited about. It's an evidence-based practice, has a good deal of evidence behind it, and really helps leverage very limited psychiatric resources. You know, while we're excited about these possibilities and have a lot of ideas about how to do things better clinically, we also recognize that some of these things are going to require pretty big changes in how we do things. And in order to start working on those changes, we started talking with both clinical partners here in Addison County, but as well as both local and state partners. We've had conversations with DEVA, Blue Cross Blue Shield, UVM Health Network, as well as AHS and the Green Mountain Care Board about how they may be able to possibly support some of these initiatives. And so far, I'm really happy to say that the responses have been positive. I'm happy to answer more questions about those things later. And before I hand over things to Dr. Williamson, I do want to talk about one other issue that is seems to be growing in importance, and that is the conversations we're having with local partners, including law enforcement and other community institutions, about some situations involving Addison County residents who are experiencing significant mental health challenges and who come to the attention of the community because of concerns about safety or their behavior. Over the past year, this seems to have intensified. The pandemic certainly has increased strains both on people experiencing distress, but also how those who are first responders and caregivers. And this seems to even intensified further over the last couple months with the implementation of the legislation regarding use of force, and some confusion about how to best implement that, or what is the appropriate response to that legislation. We have had several conversations with law enforcement about that, about what can we do in these situations that meets the standard of the law and keeps everyone safe, including those who respond. So while some of these issues are longstanding, I think they have become more complex over time. There have been initial conversations about moving forward, and I'm hopeful that will yield some fruit in the near future and in the long term. And that's it for me. Next, I'd like to invite Dr. Williamson to talk about something she's been working on.
Thanks, Joe.
Hi, thanks a lot, Dr. Lassick. Hi, I'm Genevieve Williamson. I'm a child and adolescent psychiatrist and also a general adult psychiatrist. And I am the medical director for youth and families here at CSAC. And I'm just finishing up my first trimester here. So my colleagues can all talk about the contrast between pre-COVID life at CSAC and post or in the midst of COVID life at CSAC. And I don't have that luxury of knowing how things were before, but something I heard Cheryl say was how indebted she feels to the staff here. And I have that same experience of collegiality and collaboration and really dedication above and beyond. And that means a lot to me because one of my values in the work that I do is in teamwork, working with families together. All of us who are in a helping role that we might work together. I'm really interested in open dialogue and working with families to hear about what's important to them and emphasizing the stories of youth and family members and the people that we work with rather than medicalizing distress unnecessarily, and really focusing on how to be helpful. Sometimes that involves psychopharmacologic strategies, medicine, but other times that's really the least relevant concern. And that sort of brings me to a shift in focus. My focus working with youth and families here is on the resilience of the family, the resilience of the child, the child, youth, parents as part of a network, and a group of people who have a history and have developmental strengths and areas for development, a group of people who are also part of a community, and thinking about all the things that are working well, in addition to ways that we might be able to help. And again, some of these relate to expressly to medication management, and other times they don't. I am very focused on that distinction also because I've seen a lot of morbidity in association with polypharmacy, kids being prescribed medications for problems that are either better addressed through other kinds of interventions, changes in environment, educational assessment, learning assessment, and use of evidence-based psychosocial strategies. So I'm very interested in how we can use those other strategies first, and I think more helpfully before thinking about emotional behavioral distress as necessarily a medical concern. And that's not to the exclusion of using medications, but to put medications in their proper place. So I am really interested in increasing our access and familiarity, supervision with evidence-based psychosocial strategies. As Dr. Lassick mentioned, consultation with pediatricians, primary care providers. Something we've been working on also is increasing the experience for the people that are staying in the emergency department here at Porter, for whom the experience is really can often be traumatizing and very uncomfortable. and working with the leadership in the emergency department to improve that experience. I'm also really interested in, I know that you'll hear about the living room model later on, so I won't spoil whoever's thunder that is, but thinking a lot about alternatives to waiting in the emergency department for those who are experiencing emotional and behavioral health crisis. And again, as part of an overall point of view that person-centered care is better. The other thing that I have been working on is improving the referral process to see a psychiatric to see me for kids and families, with the hope that I can shorten my intake process and be more immediately available for more kids and families. And this has been in no particular order, but I also just wanted to mention the prevention of emergency involuntary hospitalization and post EE reintegration work group, again, to improve the experience for our consumers, particularly those who are have had their right, to freely move back and forth between the ED, the psychiatric hospital, and the rest of the world limited and curtailed. How can we reduce the frequency of that experience, and how can we improve that experience for those that have to go through that? So thanks so much for giving me an opportunity to talk. Thanks.
Thanks, Genevieve. So I'd like to pivot and talk about some agency-wide initiatives that are happening. Not only are we continuing to function at a very high level and provide excellent care, and our services are broad and deep, but we're also doing some pretty innovative thinking and work around some important stuff, not only for CSAC, but for the community. So Cheryl, would you mind touching on trauma healing?
Yeah, I'll just talk about it quickly. It's a concept of really looking really systemically at how we approach healing from trauma. And the idea is we're working with two different consultants, Dave Melnick and Ken Epstein, to really look at a multi-dimensional approach that takes in supports and services for the people that we work with, but also looks at secondary trauma for our staff and the systems that we work in. It focuses on CSAC as an organization, and also our role in partnerships in the community. It looks at how do we develop safe and trusting environments, and how do we give people at all levels voice and create a sustainable system that can really go towards healing trauma.
Thanks. Hey, Alexa, do you want to tackle Learning Project really, really quickly?
We're getting CEUs, which you have to have if you're a licensed professional, can be expensive. You have to buy attendance at conferences. One of the goals of the Learning Project is to offer in-house CEU opportunities for our licensed professionals. We also are looking to pull together our learning opportunities for our direct entry staff and trying to kind of improve them systematically across the agency.
Very succinct. Sandy?
Sure. So as Dr. Williamson referenced, we're working on ideas around what we're calling, or it's what's informed by, I think, a model called the living room model, which it would be an effort to create some alternative staffing and spaces to help divert from some of the very difficult situations that can play out in the emergency room otherwise. And the hope is that with, to create a space that people would want to go towards in a time of distress, rather than the extremely difficult space that one might want to avoid at all costs. Otherwise, if they're going to a busy ER when they're experiencing a mental health crisis. We're submitting an RFI, or responding to the RFI today and submitting our proposal. It would be a collaboration between both adult and youth and family to work together on both the staffing and then maybe some different bases in terms of where the supports could be located. Staffing could also have the capacity to do mobile crisis outreach as well. And in adult mental health, we have a work group of staff clients and family members who have been working on experiences around involuntary hospitalization, as Dr. Williamson was referencing. So they're also weighing in on what might make sense with this kind of a model. And just to say also, though, that we want to be realistic that in terms of starting a project like this, we have to be realistic about what staffing costs, not expect to create a program like this, with wages that would compete with McDonald's or something. That, we want to make sure that this is adequately funded in order to try to do it.
Thank you, Sandy. So, all of you hearing from some of our frontline staff, so I'm going to stop sharing the screen. Bob, would you like to go first, Bob?
Yes, thank you so much, Rachel. Yeah. I'm Bob Doran. I'm a clinical social worker, licensed social worker at the Adult Outpatient Program. And just want to thank the legislators for all the great work you do. It's just such a wonderful state. People coming in really love living in Vermont, feel supported by government. And it's just great to be able to feel like we have that support. Just a fantastic place. I also, as others have mentioned, enjoy the collegiality and cooperation of all of our administration and the different teams we're on. And just some examples of successes we've had. I work with one person who's had sort of chronic suicidal thinking over the years. And she reflected on how helpful the dialectical behavior therapy classes were that she took, and the teaming with the psychiatric nurse, Barbara Hammerland, who, as was mentioned, recently passed away. This particular person lost her mother, her brother came close to death, and her beloved kitty who supported her. But through talking it through and going over the skills with the DBT, she was able to find closeness with her siblings that she had not had before, and has worked on the relationship with her son and her daughter, to the point that her daughter's children are also taking dialectical behavior therapy and using it with their families. So she felt like she had a great impact, a positive impact on their lives. And right now, inherited monies, buying furniture for the house, and is cooking for herself. So all these things are just so positive that we can't really advertise them as much. Likewise, another man I work with in the CRT program, he lost his brother and two nieces within a period of 1.5 years. He actually moved in with his sister-in-law, who in turn, it was her husband and two daughters, adult daughters who had passed. And on their anniversaries, they were experiencing such loss that they ended up at Porter ER with heart issues consistently when the birth dates or the dates of passing appeared. And so I offered to meet with them, and knowing their Christian beliefs and values, we're able to find some prayers that match their beliefs. We prayed together during those anniversaries, and they stopped going to the hospital at that time. It was remarkable, to the point of actually wanting to have the funeral for the brother/husband who passed away, and had great closure with that. I mean, it was just an amazing process to go through. And so I'm very thankful that we're able to experience that work here with these successes. That said, our salaries are a big issue. We lose a lot of qualified people because of the salary issue. I had one colleague who left who told me that they were going to be making $72,000 over at Porter at UVM Medical, which is probably about $20,000 or so on average higher than what we're making here for basically the same work as she described it. Likewise, we're hoping to be able to have higher funding. We understand, looking at ACSU teachers' salaries, they make up to $88,000 a year after 23 years. Something along that lines with like a STEPS model would be very helpful for us as well. I do want to cede a couple of my minutes to Carolyn Gillis, who's one of our team leaders, but to thank you so much for what you do. And we're just looking in, if we can find federal funding sources, we feel that would be a great way to help go about getting a real jump in our pay. So Carolyn Gillis is one of our team leaders who's worked for many years at Adult Outpatient. Carolyn, would you like to share right now?
Yeah, certainly. Bob had asked me to tell a story that I'd recently recounted about my experience. It was about taking my son up to see a specialist at the UVM Medical Center. And while we were waiting for the doctor to come in, so my little 6-year-old I brought up, And so a social worker came in and she said, you know, she wanted to ask me some questions about food insecurity. And she said, you know, don't worry, we're asking everyone about this. And she asked me if there was any food insecurity in my household. And I said, oh no, my kids and I will always have food, you know, as long as I have a credit card to put it on. And she said, you put your groceries on a credit card? I said, yeah. And she said, that qualifies you for a box of food. So she brought in a big box of food and gave it to me. And I felt this amazing combination of gratitude and shame. I mean, the gratitude, because I looked in the box and there was probably $50 worth of groceries there. And I thought, wow, the $50 that I won't be spending on this, I can buy my little guy some snow pants and snow boots. But then the shame was overwhelming. I thought, you know what, there are people that need this more than me. And I'm a professional with a master's degree and I should not be living paycheck to paycheck. And it's hard to talk about advocating for higher salaries when I have electricity, I have a roof over my head, I have a car that works, and that is more than many people that we serve have. And, you know, it's just, yeah, I'm not making what other professionals with the same level of education and experience have. And we make just enough to not get assistance and make just too little to really comfortably be able to afford life. And it's demoralizing to know that I could easily leave CSAC and make 20 or 30,000 more dollars, but the profession, the mission of the social work profession is to serve underserved populations. And that is what CSAC does. That's what we do well. That is my passion. That feels like a calling. I don't want to leave this work. And someone in my life told me once that my choice to work at CSAC was a self-inflicted wound, that my financial stress, I was doing it to myself because I was choosing to stay here. But I really believe that if you love something, you don't abandon it. You stay with it and you fight for it. And I feel hopeful that things are moving in a direction where we can, you know, offer people in these kind of positions a higher salary. So thank you for letting me speak to that.
Hey, Carolyn, I didn't realize you were going to speak today, and I just want to thank you for speaking up and being vulnerable on behalf of your colleagues.
You're welcome.
Tim?
Hi, I'm Tim Franklin. I'm a service coordinator here at Community Associates, which is the DS division of CSAC. I've been working here for 4 years as a service coordinator, working with adults with developmental disabilities. I want to echo what Greg Mayer said earlier about the direct support professionals and the way that they have really stepped up, many of them during this crisis, going back to when COVID first started and we didn't really know what it was or what it was going to be or how it was going to affect things. That we had a number of people who felt like they needed to be home with their kids who were not in school. But we had a core group of DSPs who were willing to say, you know, I know this client and I know that if he doesn't have his services, if he doesn't get out and go swimming, if he doesn't go out and get his hike in, if he's not able to go to work, it's going to be a crisis for him and for his caregivers. And so we had a great group of DSPs who were willing to put their own health and the health of their families at risk to serve our clients from the get-go. Like Greg said, we've been direct serving since March 13th of 2020, and there's so many great stories that I can recount about those folks being willing to in all the walks that were taken to be able to support our clients who are undergoing increased anxiety, but who really depend on their direct support professionals to help them to make it through their day, through their week, to access what community they could during that time, and to keep their lives regulated and on a schedule that's so important for many of them. More recently, as we continue through the pandemic, we have more people coming into our services. And as a DA, we can't say, sorry, we're full, we're at capacity. And so we've been having young people. This summer, I got some new young people on my caseload who are coming to us and entering into adult services. And we've really made a great effort to try and support these young people as they're coming into services. There's a young woman who works in the bakery at one of our local grocery stores and is so proud of the work that she does, and able to have her first job, her first paycheck, feeling like she is learning and growing, and would like to do more, but we're not able to staff more. Thinking of another young client who recently came into our services again this summer, who also wanted to work and get into a job. We prioritize some of these new clients to be able to give them some services, but not all the services that they're entitled to. There's a young man who's a favorite of mine who lives up in Lincoln, and I was visiting him recently. He's been without his services since the beginning of COVID. We haven't been able to provide him with the community supports and the work supports that he needs. And because he doesn't act out behaviorally or experience high anxiety, he was lower on our priority list. And so I've been trying to check in on him and visit him throughout the pandemic. And I was with him a few weeks ago, and we went out and got some lunch. And while we were eating lunch, he looked over at me and he said, I am so happy. And I said, why? And he said, you. And he was delighted to have one person that he knew coming into his life, even though he wasn't getting all the supports that he needed. And so there's so many stories like this in the DS work of people who need that connection and need those supports, who haven't been able to get them, and we haven't been able to serve them. I'm a service coordinator, kind of middle management, and I've spent a lot of time recently providing direct service because we don't have enough staff to provide those services. And at the same time that I'm providing direct services, there's an increased administrative burden. The reporting that's being required, the detailed reports to document services have just been growing and growing. Just in the 4 years that I've been here, the amount of paperwork and administrative tasks seems to have increased exponentially. And so, and often it takes more time to document the task than it did to perform it. We are stretched thin, and as has been mentioned, when one person leaves, it creates a whole wave of a ripple effect across our agency and across our division. I supervise a 24/7 residential home, and we've been short-staffed there since June. And that impacts everyone who works there, who are picking up extra shifts. It impacts clients who aren't being able to do all the activities that they're used to. It impacts me as the manager, service coordinator, having to fill in shifts and other coverages. And people are, as been mentioned, people are leaving. We had someone leave last week for a higher paying job with less stress. When you know that no one's going to throw their lunchbox at you, and no one's going to yell at you. You're not going to get any calls after hours. You're not going to be asked to come in and cover a staff shortage, and you're going to make more money. That's very enticing. I do the work that I do, and you might think that I make a professional wage, but I make less than $20 an hour. And it's hard. it's hard sometimes, and we're tired. We're all tired. One of my colleagues is leaving. This is her last week. She's tired. The constant stress, the pay scale, it all takes a toll. We're doing the best that we can, but we appreciate you being here and listening to us today. And we're just asking you to do what you can to support us as we support the most vulnerable people in our communities. Thanks.
Thanks, Tim. Hey, Emmy, I think you're our last staff member.
Hi, my name's Emmy Harvey. I'm a clinical team leader in youth and family. I've worked at CSAC for 24 years and have appreciated my tenure here. I oversee the office-based program and the elementary school-based program. And I know I have very little time, but I just want to express gratitude for my colleagues who have been working exceptionally hard in these last year and a half. This other school-based clinicians and office-based staff who've been working full on. And many people mentioned our salary, and people aren't in it for the salary, fortunately, but it sometimes it feels like it's a thin thread that we keep them because these are such stressful times, and the work has been super stressful. As Cheryl mentioned, incredibly stressful times at schools. Teachers started the year tired, from what I heard, and felt like they were 4 months in after 2 weeks in. Parents are stressed from not knowing when they have to stay home to take care of a kid or a kid that's got some symptoms. Kids are stressed because they're living in a stress system. They have been isolated. They've been out of their routine for the last year and a half. So as you know from the news and national and local news, things at schools have been really tough. And my colleagues have adapted their positions, the ones in schools, to be more supportive to teachers, taking on more kids than they would typically, helping with kids that they aren't necessarily involved with, just to be another person there because the supports are so limited. One great thing that a colleague has done is to kind of support staff. Cheryl was referencing the importance of connection and how that offers hope. One colleague started a cold water dipping club and invited all staff to join them one day a week to go jump in Lake Champlain. It's a crazy thing, but I just really appreciate she's taking the time and energy to build connection, because that's when resources are so thin, we have to rely on what we do have, which is each other. So thanks for being here and hearing about our work here in our agency. Appreciate it.
Thank you. I'm going to turn it over to all of you for questions. I'm sure you have a lot of questions, but before I do that, I want to recognize we have a lot of board members on. So if you could all just give a wave. And I hope you walk away today just knowing that we are your DA. We are Addison County's designated agency, and that you get a sense of the depth and the breadth of services that we offer and the dedication of the people who do the work. That it's really high quality. We're a responsive agency, and we're incredibly collaborative. We have deep, long established relationships with other partners in this county, and we work hard to maintain those. But I would say, as you're hearing, we're at a critical place, and we need your advocacy and your support as you move forward in your own work. And again, I'm just deeply grateful for your support and just how accessible you are. So thank you. So I'm going to open it up to you, and please, reach out with questions, and curious what's on your mind. Ask us anything. Hi, Ruth.
Hi, Rachel. Well, first of all, thank you all so much for explaining your work and the situation that you're in and how you have persisted through COVID and sharing your stories. It was really powerful. I was in tears a couple times. I have two questions. I had more and I've kind of lost them, but I do have two that one is I'm curious about Alexa, you were talking about the CMS vaccine mandate and how it's difficult. Are you having people who are resistant to getting vaccinated? Is it a mandate just for staff, or is it also for clients? I guess I admit I'm a little confused. So that's one question. And then Rachel, my question for you is, last year, although we certainly didn't give you everything you needed and wanted, we did provide some funding. I remember specifically some funding for facility upgrades and some specific programming funding, and a small, definitely inadequate amount for salary increases. But I'm wondering if you could talk about if that had any impact or not. Yeah, so those are my two questions.
Alexa, do you want to take that first?
Sure. And just a point, the increases that we got enabled us to move our hiring range for direct entry staff from 1450 to 1520. So it made a huge difference. That 70 cents an hour was enormous, with corresponding, I'm talking about the direct entry, but with corresponding increases throughout the job scale. The CMS rule is very confusing, and it came out at the same time as an OSHA rule, so people get the two confused. The rule only covers staff, not clients. We have about 20 or 25 staff who are not currently vaccinated, and I think that it's fair to say that most of them, have really strong reasons that are unlikely to be swayed by a vaccine mandate. Maybe a couple of them might change their minds, but the reasons range from thinking, not wanting to do it while they're pregnant, which makes total sense, but to me, but medical professionals are very reluctant to sign off on accommodation requests, even for people who are pregnant, which makes sense because the CDC recommends that pregnant people get the vaccine. So you've got situations like that. And then you've got situations where people are like, I don't trust the vaccine and I don't want to do it. We also have people who have have submitted religious accommodations, which we have a process to consider. Does that get at what you were asking?
Yeah, it does. I was just curious about how widespread it was. It seems to me, for the most part, with obvious exceptions, that your sort of staff group would be, eager to be vaccinated. And so that's why I was just curious about the stories that you were hearing from. But even those 20 people would cause staffing disruptions given how low staffed you are at this point. Okay.
Yes. And in fact, in some, they're not just evenly spread out like a person in every department. So there might be like a group of folks here and that would have a bigger impact there.
Yeah, understood.
Thanks.
Yeah.
Yeah,
I'm glad to hear that the salary was at least a little bit beneficial, if not fully what you needed.
Yeah, and Ruth, I can ask Bill to give you the specific numbers around what that meant for CSAC. It was just on our Medicaid dollars that we got the increase on. We were, through our COVID relief dollars and the increase from the legislature, thank you so much, able to do a pretty significant investment in staff, both in terms of wages, but in other ways, for example, bumping up the retirement, using one-time dollars to bump up our contribution for retirement, to subsidize healthcare, to do some PTO buyback because people weren't using PTO. I think the challenge is, as Alexa says, it was a bit of a race to the top for wages. It's an employee market and everybody raised their rates. So we're still competing with and falling behind people working at the grocery store for certain positions, or more significantly, our clinicians and licensed staff who are able to go into private practice or work at the UVM Health Network or in a school system and sometimes make almost double their pay. Bill, would you mind talking about what the legislative increase meant to us in terms of dollars, and also what the total cost of a 1% increase to staff to the agency?
Hi, Bill Claeson's Chief Financial Officer here at the Counseling Service of Addison County. So I'm going to go back to the original question, if that's okay. So I believe there were several funding opportunities for the designated agencies, and I believe you're talking about the earmark for equipment We never received that. I'm not sure if any of the designated agencies received it. And I'm not sure exactly why. I know why we didn't receive it, because we had already received additional funding and we didn't qualify. And I believe there's another allocation that's out there. And I think it's more mechanics on the Department of Mental Health and they're being understaffed and how the allocations would be distributed of those funds. So in no way am I complaining. As a matter of fact, I'm very appreciative of the cash flow that happened during 2020 in the advances of funds and just the stabilization of the funding that could have gone the other way and would have adversely affected our operations and ability to respond in the way that you heard that our staff did during COVID. So very appreciative for that. Going back to what Rachel asked me, if you want me to continue. Basically, it's around 120,000. In order to give a 1% increase to our staff salary, it's $120,000. I believe the 3% that we received in Medicaid was approximately somewhere between $350,000 and $400,000. So we were able to allocate that to cover or increase rather our salaries for staff, but also in other places, healthcare going up and other costs as well. So very appreciative of the flexibility of that funding. When you give a funding increase, as Rachel has requested, or the designated agencies have requested, to not necessarily tie that to salaries, which is important, but there's other costs, especially now in an era of inflation, that go up that we have to cover as well. So I'm not sure if I answered what you asked me to answer, Rachel.
Yeah, you did. Thanks, Bill. Ruth,
Sure.
did that cover it for you?
Yeah, so you did not get any of the facilities funding then?
That's there's been so many different little grants and things like that. So we have received some on smaller items, but the earmark, I think it was $3 or $4 million, and I think 2 or 3 million of it was designated to the designated agencies. We have not received that, and I'm not sure if anyone has received it.
And
Okay.
Ruth, you got that list of how we would have spent it.
Yeah,
so,
that's what I was wondering, if you were
Yeah,
able
so
to
we-
do any of those things. Okay, thank you. Other people have questions?
Amy, do you want to go? And then Robin.
Sure, thank you. Thank you all for sharing so much with us in this short amount of time. It's a little overwhelming for me because it's not my natural place to be, but I hear you, and I really do prioritize the mental health issue as like one of our top priorities for this moment in time, much less the session coming up. I think it was Sandy who talked about the embedded mental health worker with the state police. I'd love to hear more about that. And then also we've heard from our own chief here in Middlebury about the need for that in Middlebury and what we could do to make that happen for towns that have their own police.
Sandy, do you want to take that? Yeah.
Yeah, no, I think that is the intention, that not only would they be available to accompany the state police, but also to work with the town police departments as well. You know, it's one person for the county, and you know, so there's limited capacity with that, but I think that's the intent. I don't know, Greg, if there's anything you'd add with your involvement in this project.
It's certainly written into the intent, and but the service will be managed by the state police barracks.
Yep.
And there's a dynamic there that's long standing.
So Amy, the dollars to support this initiative are coming from public safety through vacancy savings. And it's so taking those vacancy savings and moving it into Department of Mental Health or to the DA system to be able to embed mental health specialists. And so it's been a really good, I think, collaborative relationship for us as we've moved towards recruiting and hiring and onboarding somebody. Greg has taken the lead on that, even though it sits within Sandy's world at adult mental health. And Chief Lozier up at the New Haven Barracks is very open to a co-response supporting other more local law enforcement like Middlebury PD. Unfortunately, it's one person. And there's only so much one person can do. So it's a test year. We'll see how it's going. We'll look at data to really understand, when we need to staff these hours and what's most critical for our response, and hopefully grow from there. There's ongoing conversations throughout the year to really refine and improve the relationship in the position.
Thank you. And my other question is, how many of you joined the Cold Water Club? No, I'm just- I'm not sure I'd sign up for that one. Thank you.
Hi, Robin.
Hi, and I'd like to also add my grateful thanks to the work that you all are doing. CSAC is such a vital, critical part of the Addison County fabric, and I'm just grateful you're all there and you're so committed to what you do. And so thank you. Thank you very much. My question, agreeing with the other questions that have already been asked, but I'm thinking about the staffing from a sort of a long-term perspective. I mean, if you could hire 50 people today, you would. But what are some things we could do long-term to develop some bench strength? I'm thinking particularly, in the past, and certainly our last budget session, we did things like tuition assistance for people who are going back to nursing school and help them with everything from their tuition to their books to maybe even some pre-courses. And so there were some education pieces, and I don't know if there's anything like that that would be appropriate for us to consider as it relates to your work, or other things that I'm not thinking about that would be helpful to just over the long term build that bench strength for you.
Yeah, it's a great question. Alexa, do you want to speak to that?
I'm really excited about the tuition reimbursement money that's coming through the tobacco settlement that's working its way through the system, has been for some time. And that money is going to be available both for prospectively for people who are going to school now or in the future, well now, or retroactively to help pay off student loans. The amount that CSAC is getting, I think, adds up to 15 people can get assistance out of our 300. And so it would be, I think it's going to be a wonderful recruitment tool. Come work for the DAs and we'll help you pay off your loans. And I wish there was greater opportunity there for some kind of tuition remission, because people have student loans and that's not something you necessarily get elsewhere.
But at the same time, it's going to be really bad for DS.
Can I jump in for a minute too?
Yeah,
because DS is not getting the money, right?
Right.
It's only our mental health staff. So there's a
Right.
huge disparity there.
There is a statewide workforce group made up of both developmental services, mental health, the Department of Mental Health, Dale, and the DA system that's trying to look at sort of the whole, a really comprehensive view of workforce and what that means. And there's like a 10-step strategy approach. And part of that is about trying to build career ladders into all of our service needs. Creating continuity and I mean, at this point, I think most of us feel like there's probably not enough workforce in Vermont, and that we need to try to build and keep students coming out of colleges, coming out of training programs, coming out of CCV in Vermont. And that means if there were loan repayment or for staying and working in a DA, that might be a strategy. But there really is about trying to identify career ladders, the salary issues. It's a pretty comprehensive report, and I know that's going to be available soon, if that would be helpful.
Yeah, I would love to see that when that comes out. Maybe you could share that with us.
Yeah, we'll make sure to send it to you, Robin. I guess the one point I'll make about our vacancy rate right now, so the number of open positions, is I don't think it accurately reflects the total number of positions we need at this agency. Because we've in the past, I think, right-sized our budget by taking vacancy savings and cutting positions. And so, for example, with our emergency team, we often have one person working for supporting the entire county. And I'll say, with this particular mix of staff working on our emergency team, out of 6 people covering 24/7, 4 of them are moms. And just think about it. I think about my own experience as a mom and having to rely on systems like school, childcare, to be able to work. And you know, those systems are largely, you know, constantly being disrupted because of COVID. And so it really has put us on very fragile footing. But I just wanted to make that point that yes, our vacancy rate is, you know, at about 15% right now, but it's not truly reflective of what I think a healthy DA should look like in Addison County.
And Rachel, just to build on that, the work that I know the legislature is interested in terms of quality early childhood education, housing, affordable housing, those things support our workforce too, because our folks are, as Rachel said, trying to, you know, they've got kids in daycare and somebody has a sniffly nose and they have to stay home, or they can't find daycare, which is just crazy. And the housing situation in Addison County is completely ridiculous. It's unaffordable. Can't find anything open. So we totally support the initiatives that, you know, support a general workforce in those areas too.
Any other questions, or are there board members or other staff who might want to speak up? We've got to, well, we're at time, so I want to be respectful of time, but if, you know, whoever can stay on, and whoever needs to stop, go ahead, Bob.
I just wanted to get back to Senator Hardy that we did really appreciate the raises that we got. They were really great. We were actually at our adult outpatient meeting. We were like high-fiving and just really felt taken care of, and it was wonderful. So just, we hope to build on that. That was just really terrific, and we're very, very happy. I mean, really, it was just like a real highlight of the year. So thank you. Appreciate it.
Thank you for saying that, Bob. I worked hard to get you that extra 1%. I advocated strongly for it. So it's good to know it was appreciated. And I mostly asked just because I'm curious what more you need. I will try again this session to get you some more because it's clear you need it.
Thank you. And if there's any way we can help you, please let us know. We're here to work together. Great win-win situations. So thank you so
absolutely.
much.
I will talk to Rachel about having some of you up to testify or via Zoom or in person.
Awesome. And thank you. And thank you, everyone. Thank you, Ruth. And thank everyone for that great work. Thank you.
Okay, well, it's been an hour and a half and we've, you know, given you a lot of information and stuff to digest. And again, thank you for your time. Thank you especially to staff for coming and taking time out of your busy day. Thank you to our board members. We're always available if you want follow-up conversations or need more information. Robin, I'll make sure you get that report when it comes out, and you know how to reach us. And I hope you have a wonderful day. Thank you for your support.
Bye, everyone.
Thanks
Bye.
for all you do.
Thanks, everyone.
you.
Bye-bye.